So welcome to the webinar 3Shape Trio Scan Path Strategy for Partially and Fully Edentulous Scanning. It is being presented by Kelly Bevington, RDA, EFDA, and Brenda Kirkin, CDA, RDA, and we will begin the webinar shortly. And now it is my pleasure to introduce our guest stars this evening. First up is Kelly Bevington, RDA, EFDA. She is our Director of Intraoral Technology. Kelly began her career more than 20 years ago as an RDA EFDA, graduating from Bryman College. She has a comprehensive knowledge of dentistry and the dental laboratory industry. Kelly has been professionally trained on most major devices, and she is able to provide expert chairside coaching. She manages the NDX clinical iOS training team and has clinically trained over 1,000 dentists and their teams, and counting. Kelly enjoys sharing her knowledge by presenting webinars and is a regular contributor to dental publications. And we also have Brenda Kirkin, CDA RDA, iOS Clinical Training Specialist. With more than 25 years in dentistry, Brenda holds credentials as Certified Dental Assistant and Registered Dental Assistant with expanded functions in Michigan. She served on the clinical faculty at the University of Detroit Mercy School of Dentistry in the Division of Clinical and Restorative Dentistry, teaching dental students technology, integration, and isolation techniques with active patients. She has taught clinical techniques across North America, including impressions and retraction cord placement. And it is my pleasure to say, take it away, ladies.
Thank you.
Thank you. Thank you so much, Jessica. And thank you to all the attendees for being here with us. We really do appreciate the opportunity to work with you, to educate you, and to answer questions that you might have about the topics this evening. Both Brenda and I are full-time employees of NDX, part of our formal disclosure for CE. And tonight we're going to talk about scanning the edentulous patient or partially edentulous patient with 3Shape trios. So just as a reminder, the course overview is specifically for the patient with partial or non-existent dentition and how best to communicate with the laboratory about your digital cases for those edentulous patients. We're going to specifically discuss and identify different ways of scanning for the fully edentulous patient, how to analyze the anatomy for those patients, making certain that you are able to capture all of those anatomical landmarks that are necessary in our physical impressions that we would take, but also in the digital. And then how to assess the post-process scans and confirm that you have everything you need before you hit the send button to the lab. So this is the clinical training team here at NDX. I am honored and humbled to lead this team. They're a great group of women to work with, wonderful colleagues. Brenda is out of the state of Michigan, and she covers sort of the Midwest. We don't have very hard defined lines in the sand, so we sort of go where is needed to support our customers. And Brittany Carey is a registered dental hygienist. Brittany covers the Western region and is out of Arizona. And then I reside in Pennsylvania and try to take more of the Eastern seaboard, if you will. So what we're going to talk about tonight is different ways and different workflows for these edentulous patients. And as a dental laboratory, what NDX has found to be the most consistently successful are different 3-appointment digital workflows, specifically for what we refer to as a copy denture, a reference denture, or an immediate denture. Now, I know we all know what an immediate denture is, right? A patient has some of their dentition still left, and we are going to remove those remaining teeth and insert a final prosthesis. But we're not typically accustomed to the language of a copy denture or a reference denture. So a copy denture really truly is that. It's an exact copy of the denture that the patient would walk into your office with. We can alter the shade of the tooth, but really that's about it. Maybe a little bit with a midline. And every case truly is patient specific. Not only patient specific, but the quality of the scan that you're able to provide to the laboratory. So a copy denture is a copy. A reference denture is you using the patient's existing denture and using it as a template, as a custom tray, if you will, for taking a wash impression inside of that denture and then scanning both the intaglio of the denture, where this wash impression is, as well as the cameo, the tooth side of the denture. So 3 different workflows that we're going to talk about tonight. We do encourage questions. Brenda and I will be monitoring the questions, and we will answer them to the best of our ability, sort of on the fly, while it's still fresh in your head, because I don't want it to be you pondering about the question instead of moving forward with the information. So first, I'm going to review a few of what these things look like, right? So we're talking about printed dentures, and this is an example of the functional Tryon, which is the maxillary denture that you see in the white colored. Both of these are printed, and the functional Tryon is super cool. It's a little unnerving, I would say, the first time you pull it out of the case box, because you're accustomed to seeing a Tryon with denture teeth and wax, and so the functional Tryon is a little bit different. But this is how the imagery looks in 3Shape when they're conducting the design. So this was an impression of the maxillary inside of the maxillary denture, as well as lower dentition for an immediate. Again, this is in the design software, and this gives you a great example of the post-stam. Setting the teeth. And this is all done in 3Shape. And then the maxillary and mandibular separately and then articulated together. And the one articulated together has the stippling and festooning. And so these are some images of the actual print happening. And that's the material that we are using is DLP. It's the Dentsply Lucitone print. And so you can see all of the arches, right? All of the gingival tone bases being printed at the same time. And then all of the teeth printed at a different time. So they're printed separately, and then it's going to be a mechanical as well as a chemical bond. So let's talk a little bit about the actual workflow. So the workflow for a copy denture and a immediate denture, they are the same. Okay, so you're going from an intraoral scan and bite record. And you'll notice on the chart, the yellow is the steps for the dentist, and the blue are the steps for the laboratory. So you're going from the intraoral scan and the bite registration, or type of bite record anyway, where then the lab receives it and they scan it into their CAD/CAM software program, which we just showed you in 3Shape. The functional Tryon is returned back to the office. That was and we'll see additional images of these. That was the tooth colored, all in one piece Tryon. And then it's going to go back to the lab for a final finish. Now, at that point, if you needed to make any type of an alteration to the Tryon, you certainly can at that point. Let's see here. Can you print a fibered look to the pink resin base? I'm going to answer that live. I believe there are 5 different shades within the realm of the Dentsply Lucitone print options, and I believe one of them is fibered. Great question. So let's talk a little bit about that process, right? So it goes from the iOS scan, digital records, and bite. The CAD review and the milled printed cam try-in occurs at the lab. Milled printed try-in, CAD adjustment, and then final finish. And the 3D workflow allows an integration of technology that we've never seen with removables before, right? So we've been doing intraoral scanning now for, gosh, almost 20 years, about 20 years now. And within the last, I would say 3, maybe 5, we've started to do digital with removables. And really the last year, 6 months, 6 weeks, it's just skyrocketing, and we're learning something new every day. So thank you for joining us on that journey.
And we have another question. Does NDX do the
Yes.
same with other scanners? Most certainly.
Oh, yeah. Yeah, yes, absolutely we do. We did an iTero one. Brittany and I did an iTero one probably about 3 weeks ago, but we received digital scans from really every scanner out there and are able to utilize this reference copy or immediate denture workflow from any intraoral scan. And if there is desire to learn more about the particular scanner that you have and what that workflow looks like for you, please feel free to reach out to us and we can provide you education on that as well. So what we tend to work with the most is the reference denture. And again, the reference denture is an existing denture that the patient is already wearing. I'm not going to go through every little detail here, but you're going to really treat that denture as though it was a custom tray. You are able to border mold it. You're able to take a wash impression with it. You would want to, of course, make sure that it is not cracked or damaged. It needs to be covering the tuberosities. You're going to want to make sure that it's clean, right? Any liners or anything that is inside of it, you want to make sure is removed prior to taking that wash impression. We have also had success with dentists doing a chairside reline and letting it fully cure. I'm going to make that statement, letting it fully cure and then scanning that instead of a wash impression. So that might not happen that day, right? You might do the wash or you might do the chairside reline and then have them come back in a week to scan the actual soft reline. What's nice about this process is the patient never has to be without their denture. And you as a clinician don't have to worry about trying to pour any models with the denture in place that day in your office. So some of the things that I've discussed about teeth not being broken or chipped or whatnot, the midline should also be acceptable. And here's some images of what these would look like. So well worn, but still acceptable and meets the clinical assessment requirements that we're looking for. Right, the base teeth are still intact. Again, it's worn, but it's still usable. It's still covering the tuberosities. And we're going to clean it before the border molding and wash impression. So this is an example of what that border molding looks like. Want to make sure that we are covering that posterior seal. And I will say that prior to, and Brenda and I know this because we have a couple mocked up maxillary dentures that we use for demonstration. But when I was at the event that we were taking these impressions, nobody had a Bart Parker with them to do any kind of trimming, and now it's a little too late to do that. But it's important that you trim it before you scan it. It will make the scanning much easier for you. Good tip here is to use adhesive prior to the use of the impression material, and you can use isopropyl alcohol to remove that adhesive after the impression and scan is taken. So let me back up one. So the lighter green is the heavier body that the border molding is done. And the more tealy green is the lighter body that the wash impression was done. And the purple blue, of course, is the bite registration. So the printed functional try-in is the maxillary arch and the mandibular arch. You just see it better on the maxillary arch because a wash was taken on the mandibular. And this is our scan path protocol for the actual scans of the fully edentulous arch. This is also included in the handouts that you received upon registration. So it's going to be, like the occlusal lingual wrapping to the buccal, occlusal lingual wrapping to the buccal, and ending at the midline frenum. And Brenda's going to demonstrate this real life as well. Gives you a much better perspective. But for those of you that have Edentulous, this is imagery from 3Shape that would look familiar to you on your actual scanner. Maxillary is a little bit different. We're still doing like the occlusal ridge, if you will, then shifting to the palate. I always call that like a little Christmas tree. And then switching off to the buccal. And as far as those anatomical landmarks, really important that you're capturing the hamular notch, that you're capturing your retromolar pads. From from a scanned impression for the reference denture, it's much easier to get the buccal vestibular muscles versus when you're scanning intraorally. And one of the things that we have found is the intraoral scan of that fully edentulous patient varies greatly. When you're retracting the lips and cheeks, you're changing the muscle compared to what it will be when the denture is inserted, right? When the denture is inserted, the lips are at rest. So depending upon how much you are retracting or not is going to, of course, depend on that final fit, if you will.
Kelly, we have a couple questions.
Yeah.
Is it easier to manipulate the scanner or to move the denture base? Probably when scanning in the hand, you really want to keep that denture stable.
Still. Mm-hmm.
And still, because if you have two moving objects, it's going to keep falling off.
It gets hairy real quick, right? So yes, I try to keep the denture still and I'm moving my hand.
And then is the return timeline on the scan versus the physical impression the same, or do you find scans have a quicker turnover?
Quicker turnaround time with the digital impressions, yes. And in many cases, you're going to go directly from the scan to the functional try-in and then functional try-in to the finish with 3 to 5 days in between each process. So it could be substantially faster, and is for those doctors that are fully integrating this workflow and they've become masters at it.
And
Any other questions?
With the printed dentures too, correct?
Yes.
Yes. Yes.
Super. So this is I do not work for 3Shape. I do not know Dr. LaRusso personally, but his reputation is truly amazing. He has a a series of trays that you can scan with. You use the trays intraorally and are able to scan. So this is a QR code if you want to learn more about those trays. I just think they're super fascinating. And he's doing a tremendous amount of work with 3Shape with these. And then this is a centric tray. So this is different than Dr. LaRusso's tray. And so you are taking the impression of the maxilla and the mandible and the bite registration together and scanning the whole thing. So it's really very interesting. This is then it articulated within 3Shape. And it's just amazing. We're going to see more and more and more of this from multiple manufacturers, I'm sure, in the near future. And it's really going to change the way we're all treating those fully edentulous patients. I just wanted to show you a few scans of partially and fully edentulous patients in 3Shape. So this is very doable. This is the type of scan that we get on a routine basis. And this, of course, is going to be for an immediate denture. But notice how well they were able to acquire all the data. I mean, really, really nicely done. Really nicely done.
And we have another one, Kelly.
Yeah.
If you're making a denture on top of locators or ERA attachments, do you scan the female or do you add the male and keep her to identify the orientation? You do both.
You would do both. So the male would be in the bone, so to speak, and then the female is going to be in the denture itself. And the nice thing with Trios is you can add multiple pages. Yeah, there you go. To the prescription, to the scans. Excellent. And that's one of those things that I mentioned earlier that we're going to see more and more of, as well as complete implant supported dentures being scanned. So look forward to that.
So to begin with, we are going to do the reference denture. And everybody can see my screen okay, correct?
Yes.
And we're going to click removable. And this is for full dentures. We're going to click for the upper and the lower. And then the material we're going to put for this demonstration for printed, because that is our accelerated 3-appointment denture workflow. If you want any more information on that, we can send that to you. And then we're going to save it. And we're going to choose a delivery date. I'm going to put a week out because that's how most of them are coming back. So how would we like to scan the lower jaw? On this one, I'm going to do for the denture. And this letter I on your Trios will always show you if you have any questions on how is my scan strategy. And for denture, it's going to have you go, just like if you're doing regular dentition, you're going to do your occlusal, roll to your lingual, and then you're going to do your buccal, and then you're going to roll from the lower flange on each side for number 3, and then 4, you're just going to do the intaglio of the scan. And I can switch it either way if you want to see it live, or I could just, because I have my camera set up too. Then we're going to come around. And right now I'm holding the denture steady in my hand and I'm moving the scanner. And sometimes when we are doing our webinars on Zoom,
You took the words right out of my mouth.
I
There can be
know.
a little bit of a lag
It's like,
with
right.
the processing of the data.
And then I'm just going to go, like, as I'm scanning around, rolling over the flange of the denture. Yeah, prepare the model. And as you can see, we have some areas that are major issues. So I'm just going to go back over that, or in real time, I would normally clear that out because there was that lag that then started building additional data on there.
Yeah.
And I always say it's like a little fluke. If you see odd things like that when you're scanning, you might as well just erase it and start all over again. So I'm gonna sit this down here. I think I'm having all that light reflection. And this is a perfect timing for this, Kelly, with we were told at one of the dental schools to use on a denture like spray foot powder, so you will not have that glare. Right now I have, like we say in a dental office, right, don't have your loops on, your loop lights on, or the overhead light on. I have two bright cameras, or two bright lights for my camera. So I'm just gonna spray this and we will see how that responds. Things like this happen in real life in an office, right?
It does indeed.
So far, I'm pretty impressed with that.
So we've known for years about scanning with
Contrast spray.
contrast spray, the Opti spray
Right.
from CERAC, or titanium dioxide, which is a chemical name. It was a spray with the 3M True Definition scanner years ago, and we were all excited to not have to use powder anymore. However, sometimes with some procedures, it can come in handy as a little tool to use to acquire the data with greater ease.
So what's happening is, since I had it sitting down instead of holding it in my fingers, it took the material from, like, I have this little napkin.
Yeah, which you could trim away and then
yes, or it should.
like,
In reality, it should take that off, but if it doesn't, then you can trim it away. And everybody knows
and,
it's a trim tool.
and part of the reason for sitting it right on the table is it can be very slippery once it is powdered as well. Somebody asked the question that they scanned for a maxillary denture today, and it was very difficult to let me see if I can pull it back up again.
So if it has not been relined, if you look at acrylic, it's thin, right? So I can hold it up to a light and light will pass through, but this powder has helped quite a bit with that lower. So if you are trying to scan a copy denture and you don't have a liner or obviously a contrasting spray, you're going to want to hold a glove underneath it so the light doesn't pass through and create odd holes. On the tongue part opposite from the attendees side, right? I will usually put, I'm gonna see if you can see that part, like a composite little snake all the way down. I'm gonna show you on that scan. So on the upper, I'm gonna put for a denture. And this is the one that we have a wash. I'm not a fan of light pink and yellow. It doesn't scan as well as like the greens and blue for the PVS material.
Yeah, agree.
So now we're going to scan, and if you click the eye, it'll tell you occlusal, and then you will roll just like you do for the buccal, and then the palatal, and then you roll on that flange, and then you finish off on the integral part. So I'm going to hold it in my hand like I normally do. But yes, dentures get very, very slippery outside of the mouth. Especially if your gloves are a little bit wet.
Yeah.
So a lot of times on the palate of a denture, it is so smooth that it doesn't recognize that. So I usually just put flowable and cure it and then pop it off and give them back their denture. But it's very, very, very important to use tray adhesive. On this one, you'll be able to see that I have an area that is pulling up. And we have to remember too that a lot of scanners, they have a certain depth that they scan to. So sometimes it's really hard on those knife edges, especially on a lower or any undercuts of the old existing denture. And if you are scanning with like for immediate and you did take an alginate and trying to scan that, most people that are having dentures, they have perio issues, right? So that scan depth from your scanner to the very incisal edge of that tooth or occlusal part of that tooth is going to be past that 17 millimeter. Don't worry about it, especially if it's going to be an immediate denture, because we don't need to see the teeth, right? They're just going to trim it right or erase it right off by the gingival tissue area.
Good point.
So now I'm going to evaluate that. I am going to fix this little part. And another thing that's very important too is when you have taken your border molding and wash, you're going to want to take a Bard Parker and trim it so you can see the teeth. And if you are opening up their video, you are going to want to just put a little bit on the occlusal. I usually do first molar, first bite, and then we're going to scan the bite on your first bite to the anterior on each side. Because if any of your material, your blue moose bite, your composite little block or wax block that you're opening their video, if you're trying to scan that to get a bite, your bite's not going to correlate together. And then you're going to have to manually do it. I trust a lot of times the computer, the trios, to correlate it together instead of me manually, because if you put your dot just a little bit off, it can make your bite off. So what we're going to do next is we're going to look at it in monochrome, which I always like to do. So I know I need to fix that little area. As you can see here, when I was telling you that there is a tear,
You can see it. Yeah.
you can see it. So let's say if there is an area that you just you cannot capture for the life of you. If you wanted to even, I was talking to one of the denture techs, if you needed to put a little material in there to scan it, you can relieve it with an acrylic burr if it's too tight when you get your monochrome functional try-in in. Don't make it a deal breaker for you if there's an area that you can't, right? It's because if you get your functional try-in, you're going to try that in just like you do an existing, a brand new denture. You're going to put your PIP paste, you're going to adjust your bite, you're going to adjust all that, if that makes sense. So
Yeah.
Go back in. And if it's like a particular area that, okay, you know that you're going to be able to get, you can then go to that spot with your magnifier, and a lot of times with the trios you can get it. So that is to scan with a wash for a reference denture.
For a reference denture, yes.
So next we're going to do is we're going to do a bite. And like I said, if you wanted to open up their vertical dimension, you would then add the material to it. And most of the time, if you're doing a reference denture, the teeth are probably ground down so far down, right? And I still like to make a note in the lab slip. We're opening the video 2.5 millimeters, whatever you have done. So now we're going to do the occlusion. And if you see on your trios, there is where it shows like a bite if you're doing for your putting your dentures together, but you're going to put these back in the patient's mouth. And it's very important too, when you're doing your wash, it's almost like a reline. If they have a lower denture, after you have did all your vascular movements, you have the patient close lightly together. That way, when you try to put the upper and lower in, at least they can occlude, right? So the 360 tray, the centric bite, that is when you're doing fully edentulous, you would put putty in. This does not do the actual vestibular landmarks. It's more of putty or your blue moose bite on that. And then when you put those together, you line up your yellow dot with a yellow dot, red dot, and then it will take your edentulous upper and put it with the bite and the lower with the bite.
Question about scanning for a maxillary denture someone had done today, and they had a challenging time capturing the mucobusal buccal fold. And so I know I've used tongue depressors. Sometimes they're a little scratchy, they're rough. So I might cut a finger off my glove and put it over to help, because you need something sort of sturdy to hold the lips and cheeks back, but you need to be very gingerly in doing so. You don't want to overextend. There is a device that was introduced to me a while ago. It's called Scan Mate, and this is what it looks like. It's autoclavable. It is anti-reflective. It has a bendable, squishy head to it, so it's very kind to the oral tissues as well. So that might be something that you would like to try for that, doctor.
So she was scanning totally edentulous then on the upper, it sounds like.
For an immediate.
So for an immediate, and then there's sometimes I take like the regular Minnesota retractors, put them in a glove, and it gets slippery. But the important thing is you don't want to pull down or up. So I have it go up and out a little bit, and that way you can get in a little bit. And that is really hard because you have to capture those very important landmarks, and sometimes scanning a fully edentulous area, if they have those high vestibular areas, it's better really to take an alginate and then, or an impression, and then scan that in. That's what I have found. How about you, Kelly? Same thing?
Yeah, same. That's one of the reasons I like the reference denture. So with an immediate, the nice thing about an immediate is typically you're going to end up relining it. So it would, you could very well capture a sufficient amount of data for the immediate denture, and then take that wash impression inside of the immediate for your final, once they're fully healed.
So I do have an alginate, so I kind of wanted to go over every bit of scanning, right? So we did almost like a copy denture. We did a reference denture.
Yes.
I'm going to dump the scan of the upper denture right now, and I'm going to scan an upper impression. And then after that, I will scan fully edentulous lower. It's a typodont, right? So like when I'm with the actual patient, I like tongue depressors. So I usually have the tongue where it's down, like I push it down and out. I usually have the patient turn their head because saliva is a big issue, right? If it gets wet, we're not getting a good scan. And it's usually more of a four-handed dentistry technique.
Absolutely four-handed.
I mean,
absolutely four-handed dentistry. And yes, Brenda's going to be scanning a typodont, and we all wish sort of yes, sort of no, but we all wish we had a fully edentulous patient that we could have in our office, or have access to an operatory to do that live. So I invite all of you that if you have that special patient that is a fully edentulous patient, to do some of this work with us and allow us to capture some of the video and work with you, getting the workflow down and integrated into your practice. We are more than open to doing that with you.
So right now I am going to scan my alginate impression. And of course, this was on a typodont, so it doesn't have like that vestibular fold, but that's when you would just go around and capture all those little areas.
I was really rather astonished at how quickly and nicely it picks up the alternate material.
Yeah, so as you see, 42 seconds, and you know, being on a webinar, it makes me a little bit shy. So as you can see, yes, it does pick it up very nicely. So that's if you have areas that you know that you can't capture in the mouth. A lot of times it's easier for yourself and the patient, especially if you're in a busy practice. You know, scanning a fully edentulous can take a while until you start getting, well, even if you're an expert at scanning, sometimes it can be a big challenge, especially on the lower with all the saliva. So a lot of times, if they don't have a denture already, take an alginate, scan it in, and make life easier on yourself. So now I'm going to dump all these, and then we're going to do a fully edentulous. So once again, scan path, you have the handouts, but anytime that letter I is for information. So gonna come and then to the midline, go back. But everybody's jealous right now because wouldn't it be so easy to do it like this in an office?
True.
And now I'm gonna come back and come to the midline and how about to the, so it's occlusal lingual. Roll and capture those areas. And it's okay if you back up a little bit because microns for a denture, especially, it's not going to matter if you have gone over it a little bit without, it's different than crown or bridge work or implants, right? Where microns are miles when it comes to fixed dentistry. So here's the lower. And yes, I like to, anything I ever do, I like to turn into monochrome. And oh, look at there. I need to capture that area better.
Yes, you do.
Well, thank you.
Well, and part of the reason why we always encourage you to review your scans in monochrome is truly that is the way the laboratory is looking at it in their design software. So just like they pour a impression in stone, this is the stone for the design software in 3Shape. So this is the way they're looking at it. The technicians are looking at it.
And mark, get, set, go. Is this little area right here important
Look
to capture?
that. Yes.
So that would be on the tissue of the lip area. So if you had a little hole there, I was going to ask the audience, but I like to look at it from the intaglio area, right? I would get more on the lingual because that's going to be too short. But that little area right there is the lip. It's the lip.
And then, Brenda, we have a question as far as the information button. Could you identify where
Definitely.
that is?
So underneath the question mark, and for those of you that have the trios, this I'm gonna go through these little icons real fast because they probably were not with our introduction to trios, right?
Quite possibly not. Yep.
So this question mark has training. Not only does it have training, but if you have a question like, how do I do all on fours, or how do I scan for just like for a locator, right? You can click on here and you can type in your question right here. Ask your question and you can find it. So that's a wonderful thing. A remote access is what I'm doing now. So we're going to get out of this little part. This little I is information. So that will give you your tips and tricks, your scan strategy, depending on what library you're on. So this is
So now you're on the impression tray.
yes.
When you hit the I, it's going to show you tips and tricks on the scan path strategy for the tray.
So now I'm going to do the I again. And it's going to say how to scan for
the edentulous oral cavity. Yep.
And the same thing, if you were doing a bridge, it'll tell you how to do it for a bridge. How to, this little 4-arrow direction is when you scan and how you've evaluated by looking at your skin in different direction. This will put it, recenter it. I call it the colored orb, is to look at it from color to stone. And this one that has like the blue, that is if you want to do a shade match with the trios. If you have too much blue, you don't have enough scan data for it to take a proper shade for whatever you're doing. Me, I say I like my eyes better than a computer, maybe because I don't trust it, but it gives you a good range in. So if you're tossed between, oh, is this patient in the A range or the C range? It will help you go more. And then, but a lot of times, if you've been doing it for a long time, I think your eyes are better, but to begin with, or like those ones that you have 5 different shade guides out and you can't figure out which one it is.
Yeah.
That's a really good tool.
That's me. I become indecisive.
Right.
And I should just go with my gut. I should just go with my gut. Yeah. Yeah.
Then the patients will say, but I want to whiten.
Yes.
So I'm going to do the scan strategy for the upper, but so let's look up here again. So all around, then 2, as Kelly said, a Christmas tree, and then 3, and then 4. And a lot of times you want to start and then you push it back further. That way you go further on that retromolar or Hamler notch and ridge, right? So now then I'm going to come here and then I'm just going to sweep. I will tell you, somebody who's been fully edentulous for a long time, sometimes they don't have those landmarks that a scanner will need, which are lumps and bumps. So sometimes I'll even take flowable or liquid dam and do that same mark. I call it a wavy snake on there and cure it. Because we at the lab, we're not going to make this, like a hole. So with their mesh mixer, they'll smooth it off. And the same thing on the side of the denture where their tongue rests, they'll smooth that. They know that that's not, they know that the patient does not have this little snaky wavy thing on their existing denture. Right, that side.
Nice.
And on this part, I will not be able to get a bite because the patient doesn't have any dentures. And if you did not have a 360 tray, sometimes I have even taken putty and put one on one side, one on the other side, mark down how your VDO is, and then put where you think their anterior should fall. But I still
we do get that, right? Where the where the doctor will create a mush bite and make some markings and measure with the allometer and the papillometer and provide those measurements to us, which are great. However, it's not as reliable as what we've experienced with the reference denture. So we know we have very consistent results with the reference denture, and that's one of the reasons that we continue to promote that. But the reality is not every patient comes in with existing dentures. So it's important to understand these scan path protocols and, the best practices in those cases as well.
Right.
We did have another question, and I'll provide my opinion, and I'd like yours as well,
Okay.
Brenda, is when scanning for a partial, would you scan the intraoral cavity, or would you take an impression and scan the impression, or scan the impression, pour it, and scan the model? I would scan intraorally, and I've had great success in scanning for partials intraorally. And sometimes I might use that zoom feature that Brenda used at one point. If there's a particular area, there's an undercut that I want to make sure that I capture. What is your take on that, Brenda?
Well, it depends like what the situation, like most of them, yes, you can. Let's say if there's a lot of saliva, they're unable to capture it with like intraorally. And let's say they've had a lot of bone loss in that area where, like, let's say they have their lower anteriors, once again, how much depth is that tooth and that drop? So if you took an impression, you're not going to get an accurate reading. The scanner's not going to have that depth of field to go deep
To
in
view
those
it,
possible areas. So I would pour it up. Then if you could not do it intraorally because of the floor of the mouth, the saliva, whatever, pour it up, scan it. And some people will say, well, if I'm pouring it up, I can send it to the lab, but then you're wasting time also, right, on shipping and stuff.
Yeah. It depends how important that digital workflow is for you as well. Here's another question. If a patient has a very large tongue, how do you get far back enough for the posterior upper palatal border if the patient is a gagger as well?
Yeah, so
four-handed dentistry is highly recommend
dentistry
that, right?
on that. And but here's the other thing too, Kelly, and you know this too, almost like for your immediate dentures, right? So those are not ideal because a lot of times you have, after you remove the teeth, and you have to use a co-soft liner in it. What happens is, back there, if they get your functional try-in, and I mean, I would scan it. If you can't get it all the way, then you can do a wash on your functional try-in, is what I'm trying to say.
Yeah, for sure.
Because on some of those patients, obviously, if they're a gagger, you can't really get an impression, right? Is that what I'm taking from that question?
That was my interpretation as well.
And I mean, some people gag even with a scanner. And what I have done.
Come on. Some people gag and we haven't even touched it.
I was like, but I will tell you what helps me on a gagger. I let them hold it too and have them look at the scanner, and we both guide it to that area. So if that patient, if you tilted their chin up, and if they're watching and you say to them, can you get it back a little bit further? A lot of times they can get it back further than us, and they're distracted because they're trying to get it for you. And I've had success with that too.
Yeah. I've got two more questions. One is in regard, I'm assuming it's an assistant. And that they're asking if they can take the impression and the doctor approve it. And I will say that every state's regulations are different, and everybody's interpretation of the regulations are different. Typically, the language is reversible and irreversible when it comes to impressions, and that assistants cannot take a irreversible, or I'm sorry, irreversible impression. So some people's take on digital is if it has a delete button and they can delete it, that means an assistant can take the scan. At the end of the day, it's your license, and it's the dentist practice and their license. So you all need to figure that out together for your particular state's regulations. A question: can you scan a wax bite? Yes, you can scan a wax bite. Absolutely.
Yes.
General, are you seeing better results, more accurate fit with the digital route versus physical? I would say we're still gathering statistics on that, right? Because it's all about numbers and statistics, but we're not receiving remakes on them. So that's one of the ways that we as a laboratory measure the accuracy. And I think you've had a couple insertion appointments. Yes, Brenda?
Yes.
Do you want to tell the story about the patient that couldn't get it out?
So, so they had a couple where the assistants, they tried to scan, and like I said, scanning a totally edentulous patient can be difficult, especially if they have the higher vestibule, and it was short because you can always, I made her promise that if I did a scan and an analog, and you can always change an analog, like I said, with the impression. And I said, which one do you want? And she said, the one that I was freaking out about you not getting that impression. We scanned that impression in, and then I was told, because she had a wedding, her daughter's wedding, like 4 weeks later, that on the try-in date, they had a hard time getting the denture out, and then she was really afraid about it, but she was happy because she knew that during her daughter's wedding photos, they weren't just gonna fly out of her mouth.
Yeah,
because she her grandpa.
Don't want to do that.
Pocket dentures.
I want to go back to one question, and that was maybe I didn't understand the question completely about scanning for a maxillary immediate denture. And I believe that was the example that the patient had a large tongue and it was difficult to capture the data. And some patients are easier to scan than others, might
Right.
be one way. And the thing I like about scanning for the immediate denture is there's not a risk of inadvertently extracting one of those very, very loose periodontally involved teeth. Any particular additional recommendations for the tongue?
Well, so to scan that patient, you probably need to tilt them almost on their back and lift their head up, almost like you're doing CPR, because if they're leaning back and their head is up, their tongue is going to relax and fall because they're trying to open up their airway. And that's how you're going to scan. Sometimes it becomes more than 4-handed dentistry. Sometimes it turns into 6. So while someone's holding one area of the tongue, the other one's holding the other, but if you can't get it that way,
we all play tricks, right? And have them, have the patient focus on breathing through their nose,
right,
or crossing their toes, or distracting them with something else as well to help relax the situation.
But if they're tilted back and open, they're going to open up wider with their
Very
head.
good. Thank you for the questions. Thank you for the engagement. It's really been a lot of fun. I hope you can tell that Brenda and I are very passionate about what we do, and we like to learn as much as we like to teach and educate, and we like to learn from you. So any helpful tips or tricks that you've experienced, please feel free to share them with us. If you want any type of one-on-one, over the shoulder, or telephone, Zoom, we can remote into your scanner and take a look at a scan with you. We're more than happy to do that.